Hi everyone, continuing with our clinical approach live sessions. So today we are going to kind of do a topic which is not really something that medicine residents always see. And definitely we're not going to go through it from the perspective of an obs-gynae resident. So we're going to do gestational rheumatology or seeing rheumatological diseases in pregnancy. So we're not going to see the approach to a pregnant patient developing a rheumatological disease. We're going to see the approach of a patient who has a rheumatological disease or is a suspected rheumatological disease who is now either conceiving, like just recently conceived, or planning conception, right? So that is what our purview would be. So why is this so challenging? So why do we need to have a separate session? Why do we, kind of need to discuss this separately? Isn't this like, just the same treatment, same approach? No, right? So obviously there'll be an impact of the disease on the pregnancy. That is, pregnancy itself is not a pure usual physiological states. There are a lot of changes that happen in the physiology, and how does each disease affect that particular change? That is one thing. In turn, pregnancy will again affect the disease, right? So pregnancy has its own changes that can up or down the disease. Sometimes it can even improve the disease, sometimes it can worsen the disease. Also, one major most important thing is the medication. So especially in rheumatological diseases, we use these strong immunosuppressive medications, possibly teratogenic medications. So that also we'll have to keep in mind. So those are the three things we'll be basically seeing through. And the basic thing is, if the patient has not conceived, if you're following up a patient who is a known case of a rheumatological disease, autoimmune rheumatic disease, then the basic kind of fundamental is to ask the patient to at least be in quiescent disease activity. Say that I'll follow you up for 6 months. If you're sure that there is no disease activity, there's no disease domain that is flaring up, then you can go ahead and conceive. So basically that 6 months timeline is one thing that you should remember, especially in diseases like SLE and antiphospholipid antibody syndrome. So we also have to, this is what something that we read in the first chapter in our obstetrics, that is your physiological changes in pregnancy, right? So it's important because pregnancy itself can cause varied changes that impact the disease, as we discussed, and also sometimes changes that mimic a disease. We'll come to that in the next few slides. So coming to changes in pregnancy, we know basics, right? So whenever there is a fetus, there's excess volume, there's increased respiratory load that is there. Obviously the tidal volume, the respiratory rate, these change, but overall total lung volume obviously would not. There are some endocrine changes which are not really important in this context. GI changes are important to note. Why? Because diseases like systemic sclerosis, for example, there is relaxed lower esophageal sphincter in the disease itself, and in pregnancy that even increases further. So that is one thing that is important. The GERD component increases. Cardiovascular changes, very important. Lots of cardiovascular and vascular, something like Raynaud's, etc., changes happen in rheumatological disease. Those change with respect to pregnancy, and of course renal changes as well. Renal changes because a lot of our management approach to these rheumatological diseases focus on the renal involvement, because we want to prevent renal damage. So there increased proteinuria, increased GFR occurs in the pregnancy state. That also impacts our approach to the disease in a pregnancy. Hematological changes, again, although it doesn't drive the management a lot in severe diseases, but yeah, you have to know how to interpret the tests, right? So for example, you have leukocytes that are decreased in SLE, you have leukopenia in SLE, but in normal physiological pregnancy, you see that the WBC count increases, the WBC mass increases. So that is one portion where you can kind of see that the leukopenia is masked. Similarly, RBC count. RBC count also, because although the RBC mass increases because of the increased plasma volume, there is dilutional anemia that occurs. So that again can show you a picture where it is the hemoglobin count is even lesser than expected. Even the cutoffs change. So in the context of a autoimmune rheumatic disease where already there is anemia of chronic disease, again the cutoffs should be kept even lower. Similarly, platelet counts also, because of the dilutional reasons, change. So apart from these immune changes, we'll discuss in a little bit of detail what the immune changes are. To be basically, to tell you, the innate immunity keeps in the usual state, that is your innate cells like your NK cells, monocytes, all of these stay normal. Overall WBC count increases a bit, as I told you, while the adaptive immunity, the T cell and the B cell function, is something that decreases. Also, this is very important because especially in autoimmune rheumatic diseases which are already somewhere immunosuppressed, in the context of a pregnancy, definitely you have to vaccinate them at least with the usual influenza and the pneumococcal virus vaccines you have to give them. Hematological, we have discussed, WBC increases, procoagulation factors increases. So hypercoagulable state does occur in pregnancy. It's a double-edged sword because in your postpartum hemorrhage situation, it kinds of helps in contributing to the hemostasis. But overall, there is an increased risk of thromboembolic phenomena as well. So that is also important to note that it's a double-edged sword. Then platelet count decreases, anticoagulation factors because of dilutional change that can also decrease, and hemoglobin also, as I told you, will decrease. Cardiovascular is well known that whole plasma volume increases, so stroke volume increases, cardiac output increases, total peripheral resistance decreases. This is important because why? Your Raynaud's occurs because of peripheral vasoconstriction. Here the total peripheral resistance decreases and your Raynaud's improves. So that is one important thing. Then renal, as I told you, EGFR increases, urine output increases, and serum creat drops. So all of this will cause increased proteinuria. For example, if a patient is having a lupus nephritis, you keep tracking the changes. Now the patient becomes pregnant. You see that the proteinuria may increase, but the creat levels may show a decrease. So that is something that again you have to keep in mind. Pulmonary, not so important in our context. It doesn't change pulmonary hypertension much. There's no exact change that occurs, but obviously, pulmonary artery hypertension, because of increased load on the heart, you cannot afford. And whenever there's a patient with pulmonary artery hypertension, you directly at the outset itself, unless it's very mild, you tell that pregnancy is not, kind of advised at all. Right? So gastro also we discussed. It's more mainly about the lower esophageal tone. Next, we see these mimics, right? So as I told you, there are multiple changes, physiological changes that occur in pregnancy that can mimic something that may be there in a rheumatological disease. For example, these malar rash, palmar erythema can mimic malar rash, or telangiectasias may occur. Cutaneous vasculitis, it can mimic. Cloasma can mimic malar rash, very common mimicker of malar rash. Then edema can occur by itself in your pregnancy because of protein loss. That can mimic a lot of things. Then proteinuria, low EGFR, that can mimic your various renal changes in various autoimmune rheumatic diseases. Hematological changes we talked about. Elevated WBC may be there, that can mimic infection, or it can mimic something like an active vasculitis where there is leukocytosis that happens. Anemia, elevated ESR, all of these are physiological changes in pregnancy that will mimic active rheumatological disease. GI we discussed. Musculoskeletal, there can be ligamental laxity, all of these peri-arthritis changes that can occur in pregnancy. They can again mimic arthralgias of rheumatological disorders. Lower bone density is something that occurs in pregnancy, that can mimic osteoporosis that usually occurs in most rheumatic diseases. And sometimes if there is abnormal pregnancy, so these were all the physiological changes of pregnancy. If there are pathological changes in pregnancy, like all of your hypertensive disorders, will come to them in slight detail ahead. So all of your hypertensive disorders, be it your gestational hypertension. So again, this is a little bit of obs here, but it's important to note because just these are very basic definitions, right? So gestational hypertension versus chronic hypertension, what it is? Chronic basically means the patient either had hypertension from before, that is before 20 weeks, or it is a phenotype of the patient, that is even after the pregnancy has resolved, the hypertension stays for 12 weeks, at least 12 weeks postpartum. So this is something called chronic hypertension. Gestational hypertension is hypertension coming during the pregnancy period, that is after 20 weeks of pregnancy only hypertension is coming, but there are no next level changes. What are these next level changes? These next level changes are what makes hypertension into preeclampsia. So what is that? The main one is proteinuria. Apart from that, also there are certain things called severe changes, that is severe features. So severe features, if they are there, even without proteinuria, also if hypertension with severe features are there, you can classify as preeclampsia. So this is a last year update only. Earlier, what used to be the case is preeclampsia means hypertension plus proteinuria. But now the new update is that if there is hypertension and there is any severe feature, for example, thrombocytopenia or impaired transaminitis, more than two times the upper limit of normal, progressive renal insufficiency that occurs with creat increased by either twice or more than 1.1 mg per dl, pulmonary edema, persistent cerebral or visual disturbances, all of these are called severe features. So severe features plus hypertension is called preeclampsia. And if more than one severe feature is there, you can call it preeclampsia with severe features. Eclampsia is basically a generalized seizure that occurs over and above it, HELLP syndrome, hemolysis, elevated liver enzyme, and low platelets. And then, chronic hypertension can also have a superimposed preeclampsia. That is, the patient already had a chronic hypertension. Over and above that, there is a severe features that are occurring. So these are the main causes of mortality and morbidity in a patient with a autoimmune rheumatic disease in a status of pregnancy, right? Because main disorders that actually impact pregnancy are your SLE and APS, and both of these cause placental insufficiency. Placental insufficiency is also caused by these vascular hypertensive disorders. So when both of these combine, there's a worsened state, right? So these are the main ones that are basically that overlap that we talked about, right? Between the disease and pregnancy. Here, the main thing that is there is your hypertensive disorders that are there, right? So next you have the changes in immune system. As I told you, the main change is your decreased lymphocytes that are there and your increased innate immunity. Increased or normal innate immunity will be there, and your antibody immunity is basically restructured. Basically, there's slight decrease in your antibody mediated one, while your cell mediated one are directly reduced or bypass. Innate immunity remains same. Implantation occurs, and while the implantation occurs, it's held by NK cells when the uterine tissue is infiltrated by NK cells. And this is something that is very important because this was asked in one of your INISS questions in your general medicine questions only. So what happens in your fetoplacental T cell milieu? What is the change that occurs? So what happens is your Th1 environment changes to Th2 environment. So I just kept it here as an MCQ. It's not important from a clinical approach as such, but for your MCQs, it's important. And also, it's important from the clinical aspect. If you know basics of immunology of something like a rheumatoid arthritis, for example, it's a Th1 mediated disease, right? So in pregnancy, when Th1 milieu is changing into Th2 milieu, diseases which are Th1 mediated like rheumatoid arthritis, they usually come down. So it's not as simple as I'm telling it. It's not always the case, but in case of rheumatoid arthritis, that is true. So that's why also this is an important thing to note. Also, lymphocyte function being decreased, it's very important. Immunoglobulin secretion may not decrease to a large extent, but pregnant specific some proteins will be there. They will suppress lymphocyte function. So that definitely occurs. So now coming to what should you do when a patient with suppose an RA or an SLE? Usually SLE and APS are the two things that you should mainly be wary of, Sjogren's, etc. Arthritis coming in pregnancy, you don't do much changes apart from the medications that are there. The medications is your main focus, but if someone like with an SLE comes in, has conceived, then you have to go through a checklist. So what is the checklist? Firstly, as I told you, you should make sure that at least last 6 months, there is no disease related activity or damage, whether it be especially your renal activity, especially your pulmonary activity in case of systemic sclerosis, etc., and cardiac activity, these should be quiescent. And also there are certain damage, like both disease activity and damage, right? So when you come to damage, something like a severe pulmonary hypertension which cannot be reversed, something like aortic valve defects, or even other heart valve defects, or severe renal thromboembolic state. So all of those things we should always take care. And also whenever there are these severe damage changes, you should directly counsel the patient that pregnancy is not a good idea, not just now, because it's damage, right? It's not something that can be reversed. So it's not a good idea in a long-term basis as well. So 6 months stability is needed. Then when you come to your testing, you basically firstly test for disease activity markers like your CRP, like your complements, dsDNA, all of that, and then you see what the autoantibody profile of the patient is. Especially you want to see ROLA and to some extent U1 RNP as well. So why do you want to see these? These are the three main ones. Especially ROLA are the main antibodies that lead to neonatal lupus. So neonatal lupus, how does it occur? Basically, these antibodies passively get transferred to the neonate across the placenta, and they cause what is a neonatal lupus phenotype. It's a passively acquired disease. So hence you should look for these antibodies, and also obviously antiphospholipid antibody screening as well you should do, because lac lupus anticoagulant is your the agent, or the is the basic test that is having the main prediction for your worst prognosis in SLE or your antiphospholipid antibody syndrome. So 6 months. And also you should remember, apart from all these, if the patient has an autoimmune rheumatic disease in the pregnancy, what did I tell you? That you should always vaccinate the patient, especially for influenza and pneumococcus as well. Then we come to SLE. So we'll be going through each of the disease, how the disease impacts pregnancy and how pregnancy impacts the disease. So in pregnancy in SLE, there will be an increased risk of pregnancy related complications, like all of those hypertensive complications that I told you about, because SLE itself modifies a lot of vasculature. So vascular remodeling happens a lot in SLE, and that leads to increased placental insufficiency, leading to hypertension and vice versa, right? So SLE before pregnancy happens, fertility is generally normal. But if there is high disease activity, again, disease is not quiescent, the patient is on a lot of steroids, and also association is there with renal disease as well. In all of these cases, there will be decreased fertility. And also, we're not covering drugs, but just in case, especially in the case of SLE, you should always look if the patient has received cyclophosphamide, because cyclophosphamide directly hits into your ovarian reserve and kind of considerably decrease your fertility, not just high dose steroids, but even your cyclophosphamide as well. Autoimmune ovarian failure in the context of SLE is something that is hypothesized, but it's not really stated very confidently, but it can even happen. So lupus flares. So now coming to how SLE happen, how SLE is in pregnancy, right? So in pregnancy, lupus usually flares, and in pregnancy, RA usually improves. So this is something that you can kind of remember as a baseline, because especially in your second trimester, etc., your lupus usually flares. And apart from this, there are certain risk factors like hypoalbuminemia, high anti-dsDNA, or high, low complements, association with Apla syndrome, association with gestational diabetes. All of these will also impact your increased flare in your pregnancy. So if there is quiescent disease activity, usually it's not a disease that flares a lot, maybe at approximately 10 to 15% only. There was one PROMISE study that was done in your seeing your pregnancy patients, SLE patients in active SLE disease. PROMISE study was done to see the outcomes in pregnancy, right? So if the disease is quiescent, it was only around 10%, but if the disease was active, those disease flaring in pregnancy increased up to 60%, right? So now coming to little bit on medications. So anti-malarial medications, that is mainly your HCQ, can be continued. Prednisolone, azathioprine, cyclosporin, all of these tacrolimus you can continue. So we'll come to medications at the fag end of the session again, but basically all of these are safe. While and also low dose aspirin, because of the major cardiovascular morbidity that is there, that is recommended for all SLE patients, because preeclampsia prophylaxis can occur and it's a significant risk for preeclampsia. Apart from this, there are certain mimics that are there. Firstly, it is preeclampsia. So distinguishing preeclampsia, which has proteinuria, versus active lupus nephritis, which also will present with proteinuria, is a challenge, right? So it's a challenge mainly because your management differs. Preeclampsia, you just wait it out. You wait unless there is any complication, then you kind of want to deliver or induce delivery. But in active lupus nephritis, you have to treat the patient, give pulse, etc. So these are two different management modalities, and hence it's important. The two main things that are helpful is your serum uric acid. So serum uric acid is elevated in your preeclampsia, not so much in your active lupus nephritis, and all the disease activity markers. So disease activity markers will obviously be increased in your lupus nephritis, not in your preeclampsia. And also WBC count. WBC count in active lupus nephritis will be decreased, while in your preeclampsia it will be increased, because usually also pregnancy it's increased, so there it will be increased. Also sediments, basically your cells, etc., in active lupus nephritis they will be there, in preeclampsia they will not be there. Then this again, you don't need to exactly know what all etiologies are there for SLE thrombophilia. It includes platelet, it includes coagulant factors increase, it includes decreased of anticoagulant factors. All of these are there. Inflammatory markers, pro-inflammatory cytokines, all of these changes will cause a thrombophilic state in your SLE. That is something that you know. So now coming to antenatal scans. So antenatal scans, if you have a ROLA positivity, it's different, because there you have high probability of a neonatal lupus. So whenever there is positivity of ROLA titers, or basically ROLA antibodies in your plot, your immune plot, then you will do a 16 to 26 weeks, you will do weekly scans. And from 26 to almost 34 weeks, you will do bi-weekly scans. So this is what you do, because mainly 18 to 24 weeks, there is a very high risk of passive transfer of your antibodies and a neonatal heart block to happen. So during this, you will do weekly scans from 16 to 26, and 26 to 34, you will do 2 weekly scans that are there. Otherwise, in a normal patient, normal in the sense SLE patient without ROLA titers, there you will do 4 weekly scan, monthly scan from 20 weeks to monitor fetal growth. And also in third trimester, you will do weekly monitoring with fetal stress test. You will basically look for IUGR, and if ever there is a normal response by the fetus, like fetal Doppler ultrasound also you will do to check for IUGR. Then coming to delivery is not something that is impacted by SLE as such. It's not an indication for cesarean. Normal obstetric indications will be there, and in puerperium postpartum period especially, there is a risk for lupus flare. So as I told you, lupus will flare or increase during your pregnancy. RA will improve during your pregnancy, right? But during your postpartum period, in your puerperium period, mainly both SLE and RA, mainly SLE more than RA, both will increase. That is, they'll flare up in your postpartum period. So here, close monitoring essential to look for all the domains that might be involved. Prophylactic therapy is not recommended. You don't need to increase high cup immunosuppression. Thromboembolic risk will be there, and for at least 4 weeks you should nicely monitor the patient. Now coming to APS maternal outcomes, everything that includes placental insufficiency. So fetal outcome is obviously there. There can be IUGR, there can be abortions, there can be stillbirth. All of that can be there. Most commonly, it's premature birth and your IUGR, especially when there are both APS and SLE, that is very, very high. And also whenever there is thrombotic manifestation, for example, a patient has had a DVT because of an APS, and even if it is the first pregnancy, there is a higher risk of that particular child being a premature birth or an IUGR baby. So transplacental passage of these antiphospholipid antibodies may cause a neonatal APS, although that is something that is hypothesized only until now. This is not a very regular thing, but although transplacental passage has been documented, neonatal APS has not been documented much. So maternal outcome, mainly placenta, fetoplacental insufficiency, and even sometimes there can occur thrombotic events also like hepatic infarct, while fetal outcomes, it's mainly premature delivery, IUGR, abortion, stillbirth, etc. And there are certain risk factors as well. For example, as I told you, LAC is the most important risk factor, lupus anticoagulant. Then younger age, APS, that is a risk factor. Then associated SLE, if it is there, that is a risk factor. Then associated SLE and all the disease activity markers, low complements, dsDNA, all of that. And also history of thrombosis. This also I told you that if these are there, then there is a worse neonatal outcome that can occur. So now coming to management. So in management, aspirin, mainly it is aspirin and heparin, right? There's nothing like warfarin, obviously you will not give because it's teratogenic. So mainly depending on the if there is obstetric APS or not. If there is obstetric APS, then yes, you will give low molecular weight heparin. If there is no obstetric APS, you look at the antibody profile. If there is antibody profile having high antibody titers, then you will yes go for aspirin. But if there is no history of pregnancy loss, there is only antibody positivity, that to low titers, then no need to treat. That is pure lab APS, laboratory APS, where you just have low antibody titers and you don't have any obstetric poor history as well. So why are you using these two agents? It's basically hypothesized that aspirin mainly will decrease your APL mediated hypercoagulability. Obviously it's an antiplatelet agent, but that basic thrombosis formation, it will decrease in the intervillous placental spaces, while your heparin will not only decrease your coagulation pathway, but it will also inhibit these antiphospholipid antibody from what antiphospholipid antibody will do is they'll inhibit the cytotrophoblast migration. So these cytotrophoblast should go migrate and cause this blastocyst implantation in the placenta, right? The embryo should implant in the placenta, and for this migration of these cytotrophoblastic cells of the placenta should be there. These antiphospholipid antibodies will basically go and inhibit that. So to prevent that, you are giving low molecular weight heparin. And also neoangiogenesis. Sometimes neoangiogenesis can prevent this nice implantation of the embryo. So that is also inhibited by your low molecular weight heparin, so that angiogenesis in the endometrium is inhibited and the blastocyst can nicely implant. So this is your basic therapy that you give an antiphospholipid syndrome. Whenever there is a thrombosis, then basically you have to give warfarin, but obviously you cannot give, so you give a higher dose. You give a therapeutic heparin dose, which is basically 1 mg per kg BD or 1.5 mg OD. Both are subcutaneous enoxaparin I'm talking about. So this is for whenever there is a thrombotic APS. However, if there is a obstetric APS only, there's no thrombotic history, then you give what is called a prophylactic heparin. So this is 0.5 mg. So this is per kg, not mg only. This is 0.5 mg per kg OD dose. So this is prophylactic heparin given in obstetric APS, while this is therapeutic heparin given in thrombotic APS. So this is thrombotic APS and this is obstetric APS. This is something that you should know as a treatment of your APS. So this was about SLE and APS, your two main diseases that are to be noted in your gestational rheumatology. Then you have UCTD and various overlap syndromes. Here it's not much important. The context of pregnancy is not much important. There's neither decrease in fertility, neither there's a lot of pregnancy abnormalities, morbidity, mortality. But one thing, whenever you have similar changes, cardiovascular changes, pulmonary changes, renal changes, obviously they can happen, right? So especially something like a pulmonary hypertension, then you have to take care, and then similar counseling has to be given to the mother. Now coming to SJS, again, the main thing that you should remember in SJS is your dryness. So dyspareunia can lead to vaginal dryness, and that can cause difficulty in your vaginal deliveries. And the second most important thing again is your antirola antibodies that can cause complete congenital heart block. So first pregnancy, if a mother is antirola positive, first pregnancy, there's only a 2% risk. So you're just screening, right? You're not giving any prophylactic therapy. You are just screening. But in the next pregnancy, once a patient already has a history of neonatal lupus, next pregnancy, the recurrence risk is around 18%. So then you have to be really, really careful. And then definitely weekly monitoring is needed from 16 to 26 to 24 weeks. And then you do weekly monitoring. Otherwise, also it's recommended, but usually in practice, it's very difficult to do weekly monitoring, both for the doctor as well as the patient, right? So usually it's not done. But if what is recommended is weekly monitoring, 16 to 26 and 26 to 34 bi-weekly, that is recommended. But if there is a previous history, then 100% you should kind of focus on this, that this regular monitoring, strict monitoring should happen. So fetal echo should be done to detect congenital heart block, and the frequency also I have told you about. Then coming to systemic sclerosis, there's a lot, but the main thing that you should realize that it's not common for a systemic sclerosis patient, because usually systemic sclerosis comes in your 40s, after 40s, and pregnancy obviously would have happened before that. But even if it does occur, then there is good outcome possibility that comes about. Although there is risk for preterm, there is risk for small full-term infants, that is there. The main thing that is usually asked in your vivas is this particular aspect. So Raynaud's phenomena, as I told you, total peripheral resistance decreases, so Raynaud's improves, but lower esophageal sphincter relaxes, so GERD worsens. Also exertional dyspnea, because of the increased tidal volume, increased respiratory rate, that also will worsen, especially in your third trimester. Then if ever a patient has scleroderma renal crisis, so firstly, if a patient has active scleroderma renal crisis, severe hypertension, then you should advise not to conceive. But if the patient has conceived, then it is a very, very poor prognosis status. Still, if you want to try, then you basically have to control BP strongly. If it is before pregnancy, then you can give nifedipine and control BP nicely. Or if it is active pregnancy in renal crisis, then obviously you have to give hydralazine, prazosin, all those beta blockers, etc., which are basically recommended in your pregnancy control of hypertension. Then coming to certain drugs like ACE inhibitors, prostaglandins, these should not be given. For example, ACE inhibitor is actually the drug of choice for scleroderma renal crisis, but you cannot give them in pregnancy because of congenital malformations, and hence you have to rely on other agents for that. So coming to RA, as I told you, one thing I told you, your TH1 to TH2 shift occurs. It shifts to TH1, so TH1 it shifts to TH2, so TH1 decreases, and your RA pathogenesis decreases, improvement occurs. And also postpartum flare is something that occurs in your RA, even SLE also it occurs. So why is this occurring? One is TH1 TH2 shift, which is caused by estrogen. Then agalactosyl IgG levels, that you just leave it off. And then cortisol levels. Cortisol levels also progressively increase in pregnancy. They do not impact other diseases. Like it's not like all the diseases are improving because steroids are kind of increasing. Endogenous steroids are increasing. All the rheumatological diseases are improving. It's not like that. But in RA, that does play a role, because otherwise also RA is improving, and this increase in cortisol also increases. So this is how RA changes in pregnancy. So how does pregnancy change in RA? So overall, unless there is very high disease activity, that doesn't change much. It's a good pregnancy outcome condition. If there is high disease activity, also not much of mortality, only low birth weight possibility is there. So if patient is in remission, then definitely you can, main thing that you should take care of while you're asking the patient, counseling the patient, is the medication only. No, not much changes you need. But if the patient is in active disease, then you would want to delay pregnancy till improvement is achieved. Then coming to myositis. Again, myositis usually has a bimodal age distribution, right? So it's either in your younger age group, something like your early 20s, or even juvenile, or something like a 50s, right? So it's not very common to see. But one thing that is there is, if myositis happens in pregnancy, then you have to be careful, because then there is a very high chance that it can kind of progress rapidly, and it can cause rhabdomyolysis, myoglobinuria also. Otherwise, it's usually quiescent. It's usually not much severe in your pregnancy. But if it is diagnosed in pregnancy, if it precipitates in pregnancy, the first manifestation of myositis, then you have to be very careful, because then rhabdomyolysis can occur. So otherwise, low risk of flare, active disease, then you should definitely take care of possible flares that can occur in pregnancy. But again, it will not be very severe. New onset disease, yes, neonatal survival drops to a large extent, and then you have to be very careful. Maternal outcome overall good, unless there is a new onset disease in pregnancy. And also, your various other management modalities is fairly simple. Methotrexate, obviously, you cannot give. Usually, you give either azathioprine or IVIG. Steroids also you give. There's no role for prophylaxis or something. Just steroid management you have to give. You have to give. So spondyloarthropathy obviously will have axial as well as peripheral component, right? So peripheral component will act something similar to your RA, your peripheral arthritis, which will improve during pregnancy, while your axial disease will worsen. Axial, you can just remember how to remember this peripheral axial. Axial, your bearing your weight on your spine, right? So in pregnancy, weight will increase, and then axial disease will worsen. So mainly here, spondyloarthropathy, you have to see how the disease is impacting pregnancy. So firstly, there is difficulty in vaginal delivery. It's not contraindicated. So this was again an INSS question. Spondyloarthropathy is not a contraindication for vaginal delivery, but yes, there is a difficulty there. So why is there a difficulty? This joint ankylosis can occur, that can hinder spontaneous vaginal delivery. Then cardiac involvement can occur, that can prevent you from putting the pressure in your vaginal deliveries. Then anesthesia. In anesthesia, because of your spinal anesthesia, it will be difficult to give because of your ankylosis. So epidural placement is difficult. Again, general anesthesia may be difficult, because again, there is ankylosis in the cervical spine, temporomandibular joint. To probably, if the patient requires an intubation, that can get very difficult. Tracheal intubation will be difficult because of the arthritis in the neck and the jaw. Spinal fracture risk, all of these are your things that you should take care of. So for example, a patient is admitted with spondyloarthropathy in your rheumatology ward, and she's pregnant, then you should mention all of these. Most likely the anesthetist will know, but still you should kind of tell him that, sir, this is a patient who, sir or ma'am, this is a patient who is a spondyloarthropathy, and he or she is having this temporomandibular joint arthritis, and then you have all of these complications that can occur. And also epidural placement, all of this can get difficult in this patient. So that is the reason why you should know this, that spondyloarthropathy can impact pregnancy in this way. So coming to vasculitis, it's not the two main ones that you should know. The main specific one that you should know is your Takayasu arthritis, because the pregnancy will not impact Takayasu much, but Takayasu can impact pregnancy, because Takayasu will cause hypertension, right? So that can worsen your any possibility of your hypertensive disorders in pregnancy. So especially if it is aortic valve disease, aortic aneurysm, then it's a very, very guarded prognosis that is there. Otherwise, it's okay. It's just hypertension that needs to be controlled aggressively in a Takayasu arthritis patient in pregnancy. So this is also what happens is, a lot of times Takayasu arthritis is diagnosed in pregnancy, because pregnancy is a hypertensive state, and then you see workup for various etiologies for hypertension in pregnancy, and you find a pulseless disease. You find that there is vasculitis, there is active uptake in your pets, etc., etc., increased ESR, and a lot of times it is first diagnosed in pregnancy. So that is one thing that you should remember. Otherwise, it's not very specific if it increases or decreases. For example, Behçet, that usually improves in your pregnancy. EGPA, MPA, GPA, all of these usually increase in pregnancy, flare up in pregnancy, probably cause a maternal death also. And when is this? When the disease is active. If the disease is quiescent, especially again that 6-month rule, if the disease is quiescent for 6 months, patient is going to pregnancy, it will not flare up much, except GPA. GPA has frequent flares, and PAN also has frequent, not very much, but mainly GPA has frequent flares, so that can occur. But otherwise, if disease is quiescent, it goes smoothly only. So coming to Takayasu arthritis, tight BP control with alpha-methyl-dopa CCP-cytolazine are there. ACE inhibitors obviously to be avoided. Postpartum monitoring also very important, especially when there is aortitis. Then you should monitor for at least 2-3 days so that those hemodynamic changes don't affect much. Spinal analgesia is recommended to prevent BP increase. So basically everything you're doing for good BP control. And treatment, you cannot give a lot of methotrexate, etc. You cannot give. Mainly it is azathioprine and your 1 mg per kg prednisolone you can give nicely. Pan, as I told you, with new onset disease and even otherwise also, there are flares that occur, especially new onset disease. Preeclampsia it will mimic, and it will kind of again cause a diagnostic conundrum. And otherwise fetal outcomes are overall okay, unless again if it's a new disease, especially in the third trimester, then it can affect pregnancy outcome. Otherwise neonatal outcome is okay, maternal outcome is slightly poor, especially in new disease. So now we come to drugs in pregnancy, right? So firstly, NSAIDs. So NSAIDs, especially in the third trimester, they can cause changes because they cause early closure of your patent ductus arteriosus, right? So that basically affects in third trimester, and they should be continued by 30 weeks of POG. So this is something that is important. Fertility conception may be interfered by certain NSAIDs and COX-2 inhibitors and should be avoided during conception cycles. And sometimes it's written, but overall you do not consider this. You can give in your first trimester. In third trimester, especially after 30 weeks, should definitely avoid. In breast milk, they can cross, and they can cross into breast milk at low concentration. However, they're well incompatible. They are compatible with nursing unless the baby is jaundiced. Then there is an increased risk of hepatitis that can occur, especially with something like an aspirin Ray syndrome can occur. So that you should avoid if the infant is jaundiced. Then coming to steroid, placental transfer will occur depending on the steroid type. So this is an important concept here. If you're wanting to treat the patient, the mother, it's a different thing. If you're wanting to treat the neonate, it's a different thing. When you want to treat the neonate, you want the steroid to cross the placenta, right? It's something like a neonatal lupus. When the child has a heart block, you want the drug to go transfer across the placenta into the child. So in that cases, you give fluorinated glucocorticoids like betamethasone, dexamethasone, which will cross the placenta. If you want to treat the mother, you want the drug to not cross the placenta, that is non-fluorinated glucocorticoids, prednisone, etc. Then these are used for mother treatment, while these are used for neonatal treatment. Now coming to congenital anomalies as such is not something that happens even if you give high doses of betamethasone, dexamethasone, but there's a possibility of gestational diabetes, SGA babies, maternal hypertension. All of these can occur, especially SGA you should take care of, and preterm delivery. In breast milk, unless you're giving at a high dose, something like a 20 mg, 0.5 mg per kg, etc., it's okay to give. But if you're giving at a high dose, then you should have a gap. You should have a gap between the breastfeeding and your intake of steroids. So that gap should be at least 4 hours. Then coming to sulfasalazine teratogenicity, it will not cause, but it can cause hemolysis. For example, especially if it's a G6PD neonate, then definitely hemolysis risk is there. And hence, to avoid that, you should give additional folate. So for that also, you should kind of take care about the possible anemia. And also sulfasalazine will interfere with folate absorption. It's a folate reductase inhibitor, right? So because of that, it will interfere, and hence folic acid supplementation should be increased. In breastfeeding, it will have an increased concentration, although generally it's compatible only, but you should always take care, especially again when there is hyperbilirubinemia, because due to displacement of bilirubin by the active metabolite of sulfasalazine, it can even worsen the hyperbilirubinemia. Then you have certain immunomodulators. These are something that you should know, and I'm confident that you know as well. Methotrexate, obviously, it's teratogenic, abortogenic. You should not give. Craniofacial and limb anomalies will occur, and you should discontinue at least 3 months, not 1 to 3 months. In places, it's given 1 to 3 months, but importantly 3 months before conception. And all of these you should avoid during breastfeeding as well. Same with cyclophosphamide, contraindicated. Rarely you give in third trimester because all the organs have formed. Then you can give, especially if it's very urgent, like in vasculitis or very severe lupus nephritis, you can give. But otherwise, it's contraindicated in pregnancy. Leflunomide is among this the worst one. Highest teratogenicity is there, and this you should actually discontinue 2 years before conception. And if you're not, obviously it's not easy to discontinue, plan for 2 years. So what you do is you give cholestyramine wash out. So you basically wash out the drug from the system, and that is done using this bile acid binding resin called cholestyramine, and you wash out the drug entirely from the body. And here also breastfeeding you will avoid. So these are something that you can give. Azathioprine you can give, cyclosporin, tacrolimus you can give. There's no increased risk of congenital anomalies, while MMF is again a contraindicated drug in pregnancy. Coming to TNF alpha inhibitors, the main thing that you should remember is the data is not very strong, but especially in first and second trimester, it's okay to give. In third trimester, what happens is if you're giving TNF alpha inhibitor, it doesn't cause much changes with respect to anomalies because obviously all the organs have formed, but it will cause a immunosuppressed state. It will kind of transport across the placenta, especially your non-pegylated. So pegylated is polyethylene glycol, right? In everything except certolizumab. In certolizumab, there is pegylated. That is, there is a peg that is attached to the active moiety, right? So this is what is certolizumab. So certolizumab will not cross the placenta. So this will not cross the placenta and can be given in all trimesters. But in other TNF alpha inhibitors, that will cross the placenta to some extent and they can immunosuppress the fetus. So again, it will not cause a lot of damage to the fetus, but what it will do is you giving live vaccines to the fetus as soon as the baby is born, that will be impossible, right? So because patient is immunosuppressed, child is immunosuppressed, so that is one thing that you should remember, and hence it is better to discontinue by third trimester. Breastfeeding, again, not much data, but only minimal transfer is seen. Now coming to one other side of things, right? Paternal medication use. So now the patient is a male SLE patient or a male spondyloarthropathy patient. What are the main drugs that you should take care of? So three main drugs: thalidomide, not our rheumatological disease thing, except in some, Behçet, etc. Thalidomide is used. So there you should always avoid that. Cyclophosphamide, again, it's to be avoided because it causes germ cell damage. So that will again may cause mutations and even decreases fertility. Sulfasalazine, that causes reversible oligospermia. You should at least few months before conceiving, you should avoid. It's not teratogenic, but it's basically causing oligospermia. So thalidomide, cyclophosphamide, sulfasalazine, if you see these drugs on a prescription of a young male, then you should advise him that if you are conceiving, then you should take care that these medications are changed. Then compatible, you should remember that MMF, something that is very teratogenic from the mother perspective, that is something that you can give. And even methotrexate, it's not teratogenic as such. Then unknown safety, there will be a lot of new drugs including your JAK inhibitors, etc. So again, these are the main drugs for paternal use. So coming to again of kind of summarized one where we are seeing maternal changes. These are the drugs which have minimal risk. Hydroxychloroquine, very, very safe. In fact, it's one of the best drugs for SLE mother because it prevents to a certain extent neonatal lupus as well. Sulfasalazine, almost no risk. IVIG, almost no risk, compatible in lactation as well. Unfractionated heparin, all of these anticoagulants may cause bleeding, but otherwise they are compatible. Then low to moderate risk, NSAIDs we discussed, steroids we discussed, azathioprine, etc. On all of these TNF alpha inhibitors also we discussed. Especially certolizumab can be given actually, but others should not be given. Colchicine also can be given. So these are high risk to be avoided: methotrexate, leflunomide, cyclophosphamide, MMF, and warfarin. These are teratogenic, and these are also important drugs. So especially one thing I would say, that unknown risk rituximab is slightly something that is debatable, because a lot of times rituximab is a very strong drug that you don't have other choices, right? Azathioprine, cyclosporin, tacrolimus, TNF alpha inhibitors won't work in SLE much. All of these are actually mild drugs, right? So the only strong drug that doesn't have a high risk is your rituximab. So rituximab sometimes is, especially in third trimester, etc., it is given in pregnancy. Again, you have this risk of immunosuppression in fetus, but what to do? You have to take care of the mother first. So rituximab is still given, although it is unknown risk and avoid is there, but it is still okay to give rituximab. Others, we have very less data and better to avoid them. So this is about the gestational rheumatology that we discussed. So main thing that is usually asked in exams, vivas, and what you should know is the last portion, that is the medication portion. And the other thing, even if you do not remember, you can always come back to this lecture or go through your notes. So for example, you have an SLE or a scleroderma patient, you can come back and this is your summarized version. That this is all you need to remember when you see such a patient conceiving or planning conception. So coming to the next topic, it's basically, can give me a second. Yeah, so this is something that is usually referred to primary immunodeficiencies, but slowly the pediatric societies have kind of changed this to inborn errors of immunity, because it's not just the immunodeficiency but also the immune dysregulation also that has to be taken care of, that has to be kind of studied along with the immunodeficiency. So this is definitely a better term, although it's not something that, it's not like PID is a wrong term or something. It's perfectly fine, but IEI is a more encompassing term, including immune dysregulations as well. So before we go ahead, the basic rule, the first and foremost rule, whenever you read PID, approach PID from a studying perspective, is to not go into much depth unless you're going into a specific disease or you're doing a research in a specific disease, or in general in PIDs, you need to go into depth. But otherwise, even as a probable rheumatologist also, you do not go into much depth, because at the end of the day, it's something that you firstly screen, you diagnose, and then you kind of see what are the nitty-gritties of that, because there is so much in PID, in the PID world. Unless you're a pediatric rheumatologist, you would never deal with so much of that, minute changes that are there. So firstly, you should be, sure that you're mainly knowing the basics and the approach. That is the first and foremost thing. And then you can remember the genetics, inheritance patterns, and basic clinical presentations, and your specific physical findings. That is, these are your main things. So seeing what is PID, PID is something that happens on a genetic basis. The abnormal immune development, abnormal immune function, usually present at birth, may manifest later as well. That is, it's present at birth in the form of your genotype, but phenotypically it can present later. Then it can also not just increase infections, but it can also manifest as autoimmunity, malignancy, allergies also it can cause. It can be monogenic mostly, or it can be polygenic as well. So firstly, before you label any patient with a primary immunodeficiency, you should always rule out a secondary immunodeficiency, which we obviously all know. And these should be ruled out first, either because of all these cases or even because of outside external agents like drugs as well. So we're not going to go in depth about each immunodeficiency disorder. That's not the concept of this session. Mainly, we're going to go through how to approach a probable primary immunodeficiency. What are the tests you'll do? What are the history, physical examination you will do? We're not going to go in depth about each PID and study about that, right? So it's obviously better if you know a little bit about each PID, because if I tell you that, okay, this disease, this will be seen, and you have to look for this in this particular disease, if you don't know about the disease itself, then you might feel a bit confused. So if you know a little bit about each disease, that would help you as we go through this session, right? So immunodeficiency is keeping it very simple. It's not as simple as this chart shows, but let's just see it as with this for now. Even if you have this particular clarity in mind, that is also enough. You can build upon this, right? So specific immunity, basically B cell, T cell combined, complement deficiencies, that is your innate immunity pathway, as well as phagocytic. Both of these are your innate pathway defects. So how Harrison classified is it is slightly complicated. Again, more or less simple only. If you look at the pediatric society classification, it's very, very complicated. There are 10 classifications in PIDs that are subdivided again. So you do not go there, right? So firstly, go step by step. PIDs, firstly, innate immunity deficiency. What are the three arms of the innate pathway? Phagocytic, uh, you know, phagocytic system, then you have the complement system, then you have the signal transduction system, where you have your toll-like receptor. So toll-like receptor damage here, leading to Mendelian susceptibility to mycobacterial disease. Complement deficiencies, again, classical pathway, alternative pathway, lectin pathway, either of the pathways can be defective. Then phagocytic cells, either it can be because of impaired production, something like a neutropenias, it can be because of impaired function, like your impaired adhesion, impaired killing, because of impaired release. Anything can happen. All of these are part of your innate immune system defects. Then we come to the adaptive immune system. So these are the more severe ones. Especially T cells are the severe ones, where it can cause something like a Dijot syndrome. And also there can be combined defects also. Combined defects, especially your severe combined immunodeficiency, it is kept under a T cell defect. Why is that? Because T cell defects are leading to B cell defects here. Although both T cells and B cells will be low, but it's mainly firstly the T cells and then the B cells. Then also B lymphocyte defects like your IgA deficiency, your Bruton's 𝗥𝗵𝗀𝗶𝗶𝗶 or X-linked 𝗥𝗵𝗀𝗶𝗶𝗶. Then you have your combined variable immunodeficiency. All of these are your B cell defects, and all of these T cell defects are also there. So again, I'm telling you, if you do not have an idea, if you're reading this topic, you're seeing this topic for the first time, you might feel that, okay, it's a lot coming up. So if ever you're seeing this session, it's fine to just kind of read this, go through this for now, because you'll have chunks that you will understand, and you'll kind of know how to approach PID. But to understand each bit, you will have to read a little bit summary of your PID. You can go through our PID video that is there, that is very well summarized. It's just a 1.5 hour video where we have summary points of each PID. If you can see that and come back here, it'll be very much easier to understand. Right, so this is about innate immunity. It cannot just be about just the deficiency part, but also the regulatory defects, like all your autoinflammatory syndromes that HLH or MAS, adaptive immunity dysregulation, can occur with your ALPS, that is autoimmune lymphoproliferative syndrome, or your IPEX syndrome, IPSED as well, where you have a lot of candidiasis, endocrine abnormalities, dysplasias, ectodermal dystrophies, etc. So this is how we distribute them in terms of demography. So what is the most common primary immunodeficiency? As you see here, the major chunk is by antibody deficiencies, and out of that, it is IgA deficiency, which is the most common primary immunodeficiency that is there. Right, so you have warning signs. So whenever you have a child or you have an adult, so these are two different tables, two different charts. You have to use these particular warning signs, and out of these 10, if you have two, then you can proceed that, okay, this is a probable primary immunodeficiency case, and then I will work up for the primary immunodeficiency modalities. Right, so firstly, again, I don't want to kind of read them out. Basically, you have severe ear infections, sinus infections, pneumonias, deep-seated infections, organ abscesses, mouth or fungal infections, need for IV antibiotics, deep-seated infections, again, family history of PID. So to tell you, it's just about, and similar ones in your adult also. You have to kind of try to remember them. Even if you do not remember them, at least you have to keep this in mind. So what do you have to keep in mind? It is abnormal organisms coming and kind of infesting your body, causing infections. Then abnormal severity, as you see, severe sinus infections is written, or there'll be deep-seated infections, that is your abnormal location. Then there will be abnormal frequency. I'm just kind of simplifying what this list is, right? So abnormal frequency and your abnormal treatment requirement. That is, you need a lot of antibiotics, you need high grade antibiotics, and also you need it for a long time. For example, you see here, this is one of the factor that is there, that is 2 or more serious sinus infections, and also 2 or more months of antibiotics with little effect. That is, you need abnormal treatment requirement as well. So this is what it says, and also family history as well. So recurrent viral infections, chronic diarrhea with weight loss, all of this is there, with normally harmless TB like bacteria. This is for adults. Just see this. Just keep in mind that this is for children and this is for adults. Right, so they're more or less similar only. The basic concept is abnormal organisms, abnormal severity, location, frequency, abnormal requirement of the treatment, and all of this is basically, along with family history, are your main warning signs for immunodeficiency. So apart from this, obviously, you will consider other secondary causes, right? For example, if you have an allergic disease, you have a higher chance of recurring infections, daycare attendance, you have a higher exposure, school-age siblings, all of this is basically higher exposure, either locally in your respiratory tracts, GI tracts, etc., or higher external exposure that is there. Foreign body, motile cilia syndrome, all of these are increased exposure to organisms. So these are kind of your secondary immunodeficiencies that are causing recurring infections. So firstly, you will have to rule out all of these secondary causes of immunodeficiency. Especially in children, you have to rule out all the nutritional causes, even not just intake, even something like intestinal lymphangiectasias, they can cause loss of proteins, loss of immunoglobulins, that can lead to something that is looking like a primary immunodeficiency, but it is a secondary immunodeficiency. It's not a decreased immunoglobulin production or something, or a dysregulation at the function level. It is mainly loss of these immunoglobulins because of a secondary cause like intestinal lymphangiectasia. So all of that can occur. Then hypogammaglobulinemia can occur in thymoma because of Good syndrome. All of this you should remember and rule out as secondary causes. Then coming to age also will depend on what is the arm of the immunity that is impaired. If it is T cell, it will be very early. If it is B cell, usually for the first 6 months, it will be normal. Why is that? Because maternal antibodies, right? Maternal antibodies will come into the fetal circulation. They will compensate and they will not manifest in the first 6 months. Granulocyte defect, again, very early age. Complement defect, it is something that is quite variable. Complement defects usually manifest with weird infections and also autoimmune manifestations, so these can present at any age, but granulocyte and T cell defect, they usually present early. So it's not just the age, but also various others. For example, site of infection. For example, if you have mucosal immunity, mucosal changes like mucosal infections like otitis media, sinusitis, pneumonias, all of these basically mean your humoral component of the immunity is defective, right? So as you see, B cell deficiency is mainly your humoral immunity. So in humoral immunity, you will have your sinus infections like otitis media, ear pneumonias, your nose, all of these will be there. And also B cell defects will cause your encapsulated organisms to proliferate. Encapsulated organisms like your Streptococcus pneumonia, Haemophilus influenza, Neisseria meningitidis, all of these, you can remember this as Shin organisms, encapsulated organisms. These will also increase in your B cell deficiency, lead to sepsis, meningitis, etc. Skin infections can occur in your phagocyte, your innate arm, your barrier arm. Whenever that is defective, skin infections will occur, something like neutropenia. Then also in B cell defects, complement defects, etc. And then gingivitis, organ abscesses, and lymphadenitis. This is very, very important because these comes in your innate abnormalities, whether it be phagocyte defect or decreased neutropenia. Basically, your phagocytosis defect only. These are your classic signs that occur there. Gingivitis, organ abscesses, even something like your chronic granulomatous disease, there will be increased abscesses that are formed. Candidiasis, classic of your T cell deficiency. So this is what happens whenever you can see it both ways. For example, you have diagnosed a patient with a particular PID, whether it be neutrophilic or T cell, and then you can anticipate what are the infections that this patient can occur. And the other way is that you found out an infection in an already existing probable PID. A patient is having recurrent infections. You have not diagnosed the patient yet, but now he is presenting with something like an encapsulated organism infection. Then you can consider mostly it will be B cell or sometimes maybe even complement. If the patient is presenting with enteric, again it will be B cell, enteroviruses, B cell infection. Abnormal mycobacteria, TB, again mostly T cell defect or NK cell defect, or there will be one gamma interferon. Gamma interferon basically causes your macrophages to kill TB, right? So that is, if that is defective, then mycobacteria. Then catalase positive organisms. This we have discussed in detail in the pathogenesis of chronic granulomatous disease, why catalase positive organisms will be killing your new patients of your CGD. Then viruses. Among viruses also, I told you, enteroviruses, rotaviruses, all of these GI viruses, B cell abnormality. Other viruses, usually T cell abnormality. Epstein-Barr virus, X-linked lymphoproliferative disease. This again slightly complex pathogenesis that you can see as well. So these are your various history with respect to your pathogen which has been found that can kind of give you a clue about what PID we are talking about. Fungi, again, if it is Aspergillus, why is it phagocyte? Because this is catalase positive. So catalase positive organisms will have infest in your phagocytic defects. Then parasites, again, B cell, Giardia, Toxoplasma, T cell. Mainly more than Toxoplasma, etc. Giardia, always remember, humoral immunity is killing Giardia. So whenever humoral defect, B cell defect is there, Giardia will increase. PCP, Cryptosporidium, needless to say, it will be more in T cell. So how to remember B cell? Mainly everything that involves your lumen, right? So whenever there is no nasal lumen, whenever there is GI lumen, whenever there is respiratory lumen, mucosal infections, that will be B cell. Then encapsulated organisms, I told you, B cell. Then Giardia is something that you should remember, B cell, right? So, and enteroviruses, rotaviruses. These are your 4 or 5 things that come in B cell abnormalities. T cell, simply remember what are the opportunistic infections you read in your HIV, right? So all of those HIV opportunistic infections will be increased in your T cell defect, as simple as that. Then your phagocytic defects, you should remember mainly these 3 that I told you: gingivitis, stomatitis, organ abscesses, skin infections. These are important. Then you have your catalase positive organisms. These 2 are very important in your phagocytic defect. So this is how from the organism you can get a clue, and also from the disease you can anticipate what pathology will occur. So coming to examination, again, for this you need to know what each phenotype of your PID is. For example, general things, there'll be loss of weight, you have to do detailed, continued longitudinal testing of your weight and height, that you have to do general appearance, you have to kind of continually see, because so that you have to see, look at all of these listlessness, basic general infection manifestations that are there. The skin and mucosa, especially for your, again, as I told you, your phagocytic defects, you have to see dysmorphic features like your Dijk's anomaly, where you have a T cell defect, that will be there. Then absence of lymphoid in your B cell, where you have your humoral immunity loss, especially in X-linked 𝗏𝗏𝗀𝗏, there will be complete absence of tonsils, complete absence of lymphoid tissue. Then respiratory ENT examination you have to do to look for bronchiectasis, sinusitis, etc. GIT manifestation, you have to see hepatosplenomegaly also, and neurological examination also in your ataxia, telangiectasia as well. So all of these you have to do to kind of zero in on your diagnosis. Then some hallmark special features. For example, Wiskott-Aldrich syndrome will have your severe eczema and petechiae. Then leukocyte adhesion defect, which is a phagocyte abnormality, that will also have delayed umbilical suppression, poor wound healing at the umbilical stump. Then if it is T cell or B cell, basically your adaptive immunity, at your vaccination there will be abnormalities. The vaccine can itself overpower the immunity, it can cause BCGosis, paralytic polio, etc. can happen. Then Dijk's anomaly, this is a parathyroid, pharyngeal arch is abnormal there, so parathyroid has decreased, hypocalcemia is occurring, hypocalcemic tetany. T cell defect, again, whatever you're transfusing, it is not able to take up there, it is causing a graft versus host disease caused by metal engulfment or any blood transfusion that can occur. Then arthritis, as I told you at the outset, immunodeficiency can lead to autoimmunity as well. So some arthritis which will not fit into JIA, juvenile idiopathic arthritis, that can occur in 𝗥𝗏𝗀𝗏𝗃. Then complement deficiencies, early complement deficiencies, etc. As I told you, autoimmunity will occur, and B cell related defect as well, something like 𝗥𝗏𝗀𝗏𝗃, which will cause arthralgias. Then molluscum contagiosum, does it occur in something like HIV? Yes, it is a possibility. Extensive warts, yes, HIV occur. T cell disorder, dysplastic features. So these are your various manifestations. I'm not going to go into each of them. Eczema we discussed, sparse hair in certain PIDs. Only one thing I would say, ask you to remember, is your cartilage hair hypoplasia, because this is given your Harrison's. Then ocular telangiectasias, albinism. So this is important because they may ask you especially in your NEET assess MCQs, these are being asked. So they may ask you oculocutinous albinism, Kschidiakigazi, ataxia telangiectasia will cause ocular telangiectasias. Then Owen syndrome is not needed. Hyper IgE is important. We have discussed this in detail. So these are something that once you know what the PID is, then you can come back and it will be very easy to remember that this particular phenotype will be seen in this particular disease. Hypoparathyroidism, I told you, autoimmune IPEX syndrome, etc., Epstein syndrome, all of this will be there. Endocrinopathies will be there. Then X-linked 𝗥𝗏𝗀𝗏𝗃, growth hormone deficiency can be there. Then various autoimmune cytopenias can occur, especially in your B cell defects. Then bony dysplasias, again, this is given, so this is important. Bony dysplasias can occur in your cartilage hair hypoplasia. So these are very important clues that you can get from examination to kind of again zero in on a possible diagnosis. So yeah, so this is what I was telling you. Antibody defects, pulmonary GI infections, and also autoimmune diseases will occur, cell mediated. This basically remember HIV. So PCP, GI viruses, all of these GI viruses, more of B cell defect. Enteroviruses, more of B cell defect. Complement, basically complement, we have a separate list. If you remember, this is something that is asked a lot in our PG entrances as well. Early complement deficiency, you have sepsis, Staph aureus infections, all pyogenic bacteria. Then you have terminal complement, where you have Neisseria infections. This all you will definitely know, I'm sure. Shin infections, that is your encapsulated organism infection, also occur in your early complement deficiencies, and your early complement will cause SLE as well. Phagocytosis, I told you, basically gingivitis, skin abscesses, all of that is important. Regulatory T cell, basically whenever regulatory T cells are going low, then what happens? Regulation doesn't happen, increased inflammation happens, autoimmune diseases happen. So this is your Harrison table, again not clearly given. This is saying what test you want to do. So basic frontline test, you will obviously do the blood counts. If there is decreased blood counts, you will suspect like something like neutropenias. While if leukocyte adhesion defect, what happens? The leukocytes are not able to adhere to the wall. So there is increased leukocyte count in the blood because they are not adhering. So they are come into this, flowing blood, and you have an increased count of leukocyte. It will be much high. It will be like 25,000, etc. So lymphocyte counts, you'll have to do T cell immunodeficiency. It will be low. Eosinophilia in certain syndromes, they'll be elevated. Then chest X-ray, obviously you have to look for thymus presence or not. For example, in Dijk's syndrome, severe combined immunodeficiency, this will be absent. Then costochondral junction abnormality, there will be some bony dysplasias that occur in ADA deficiency. So this is a type of your severe combined immunodeficiency which has bony dysplasias. Then bone X-ray, cartilage hair hypoplasia. So cartilage hair hypoplasia has come 3 times, and this is given in your Harrison in good detail. So always do not ignore this cartilage hair hypoplasia. So metaphyseal ends, there will be dysplasias that occur. So rest we will come to. So this we will see, and USG also you have to see for spleen size. Right. So this is how we screen for PID. So whenever you have a B cell defect, what is B cell doing? It will release immunoglobulins. So what do you do to screen for them? You will do titers. So you will do levels of immunoglobulins. What is isohemagglutinin? So you remember how your blood groups are formed, right? So because of certain GI bacteria, these antibodies are formed, whether it be anti-A, anti-B antibodies. These are, kind of released in on exposure to certain antigens. For example, if there is a blood group patient, A blood group patient will have an A antigen, anti-B antibody will be there because of exposure to some B antigens in your GI bacteria. So those titers, for example, I am an A plus blood group, so I should have an anti-B titer, right? So if those are called isohemagglutinin titers. So those titers, if I'm not having, so that basically means I'll have some B cell deficiency. So that is what it means to screen for isohemagglutinin titer. So that is a natural titer that I should have. If I don't have that, then possibly I might have a B cell deficiency. Similarly, you are giving me some infection from outside and seeing how my body is responding to that particular infection. You're inserting diphtheria, pneumococci, haemophilus, and then seeing whether I'm producing antibodies against that. That is also a screening, that is seeing a response to a vaccine antigen. So these are your basic screening tests for B cell deficiency. Then advanced test, you can count the B cell, you can enumerate the B cell, that you can do, or you can some new vaccines you can test for. That is your basic one. And then advanced level is biopsying. You're biopsying the lymph nodes, seeing how many B cells are there. So that is also your next level one, or some special antigens you can kind of insert and see. Then coming to T cell basic, obviously lymphocyte count, chest X-ray for thymus, T-late skin test, something like man2, candidal skin test, all of that you can do. Then advanced test, T cell subset enumeration, that is how many T cells, Th cells are there, how many Th1 cells are there, Th2 cells are there, all of that you can do. If you're just looking for CD3 is your basic T cell marker, and then your CD4 Th cell marker, CD8 Tc cell. This much is your advanced. But if you're doing Th1, if you're doing Th2, Th17, then that is advanced flow cytometry. That is your research-based test or special test. Then HLA typing you can do. What are the HLAs that you have? Then chromosome analysis, genetic testing. All of these are your advanced tests. Phagocytic, basically you see your basic, if it is leukocyte adhesion defect, then increased WBC count. Otherwise, neutropenias, decreased WBC count. Then respiratory burst assay. Respiratory burst assay, you basically, if you remember, dihydrorhodamine test and nitrobrood tetrazolium. These are two tests where you basically trigger macrophages, give some antigen or some foreign molecule, and you ask the macrophage to produce respiratory bursts, that you ask them to produce peroxides, superoxides, and eventually that myelohalide system will be there, which will kill the external organism. So you'll basically trigger the macrophage to cause this respiratory burst. So that is your basic test. And then your advanced test will be adhesion molecules. You want to see in your leukocyte adhesion defect, you want to see these integrins, selectins, etc. That is there. Then mutation analysis also advanced. Complement defect, this also, I'm not sure if you can gauge from this simply just putting a small box here. You better go to the complements and cryo chapter that is there, the session that is there. So we discuss CH50 is for classic pathway, AH50 is for alternate pathway, and also if you're looking for C3 will be there in both classic and alternate, while C4 will be there only in your classical pathway. So whenever you're seeing C3 level, you're testing both classic and complement, both are active, it's okay. Then C4 you're testing only for classic pathway. That is, if your alternate pathway is defective, then your C4 level will still be normal because it's not a part of your alternate pathway at all. AH50 is basically for your alternate pathway. So how do you test in stages? So firstly, you will do your basic test that can be you can be doing in a normal laboratory, normal biochemical laboratory, or a hematological laboratory. Your CBC, ESR, basic lab test to look for any hypocalcemia, any abnormal changes with respect to LFT, RFT, any hepatitis, etc. And culture sensitivity you will do, and also you will screen for various common infections and secondary immunodeficiency. Very, very important. Never, never forget HIV when you're testing for a PID. And immunological profile also. Basic tests only, IgG, A, M, and E. You're not doing the next level test. What is the next level test? When you're doing a breakdown, that is the subclass analysis, that is you're looking for IgG1, IgG2, all of that. When you're doing that is called IgG subclass analysis. Then you're doing the complement level. This also comes in stage 2. So stage 2, what comes? Vaccine responses. Vaccine responses also we discussed. You're giving the vaccine, you're seeing whether the B cell is producing antibodies. So you're seeing vaccine response, you're seeing the isohemagglutinin titers, ASO titers. These are natural titers that are there in everyone's bodies, except maybe like AB blood group will not have them, but otherwise all other blood group will have isohemagglutinin titers. AB also will have some other hemagglutinin iso titers that will be there. Then lymphocyte phenotyping and subpopulation. So this also is basically what you call as TBNK profile, or you call it as lymphocyte subset. So here you're basically doing your flow cytometry, and using your flow cytometry, you are kind of getting cells, right? You're taking CD3 positive, that means TC cell, right? CD3 positive, basically T cell, right? So then you'll again get CD4, TH, CD8, TC. Like that, you'll basically kind of see all phenotype, all these cells, subpopulate them, and check for the amount that is there. So these are your main one: vaccine responses, IHA, isohemagglutinin, TBNK profile, and your basic complement test that is there in your stage 2. Stage 3, you go slightly more deeper. You give special antigens and see lymphocyte proliferation. You're giving some special, external antigens, and you're seeing how the lymphocytes are proliferating. Neutrophil burst we discussed about, DHR and NBT, that will be seen in for your phagocytic abnormalities. And NK cell function. NK cell function, what happens is whenever NK cell is triggered using some cell line like your K562, it will release chromium. So whenever chromium is released, that will cause, you will radio label it and you will assay it, right? So this is your NK cell testing. This is also stage 3. Stage 4, your basic genetic analysis will come, which is usually a lot of times we jump to it very early, because these tests, stage 3 tests, are sometimes even more costlier than genetic analysis. And also your leukocyte adhesion defects, and also cytokine analysis. Cytokine analysis we rarely do, because a lot of times we don't have the reagents only. So mainly it is genetic analysis here, leukocyte adhesion test, and your next level complement test. So basic complement is your CH50, C3, C4. Next level is your individual complement, C1 to C9, everything you will check, and your AH50, your alternate pathway testing also you will do. So this is your summary, where you have your, B cell, you have these infections we discussed about in detail. Then you have, this is the test that you will do. What will you do? You will see immunoglobulin levels, immunoglobulin titers, vaccine titers you will see. And when it is a T cell, you will basically look for these HIV opportunistic infection area. And what is T cell receptor excitation circles? These are basically some, substrates that are there in during the formation of T cell receptor, that are decreased in your severe combined immunodeficiency. So that is also low. And you do other tests, that is your basic lymphocyte count, etc. This is already we have discussed. This is something that is basically summarized into one image. So you can take a screenshot and you can keep it as a, basic overview of approach, as well as infections that are there in each subtype of primary immunodeficiency. Then this is, again, these are kind of flow charts. If ever you have an antibody production defect, your B cell defect, these are the ones that are there. We discussed which are the main infections that are there. If it is more than one side, usually it might be a PID. Then you examine for tonsils, lymph nodes, etc. In your X-linked gammaglobulinemia, in Bruton's gammaglobulinemia, it will be not there. Tonsil lymph node will be absent. Then you go for lab evaluation. Mainly, you will focus on immunoglobulin profile. If it is there, okay, then you will confirm it with genetic analysis. You can type what is the disease that is there and what is the treatment. You will replace immunoglobulins, and you will give antibody prophylaxis, antibiotic prophylaxis, as simple as that. So antibody prophylaxis as well as antibiotic prophylaxis, you can remember like that. Then if it is cell-mediated immunity or combined defect, again, these are the main manifestations that will occur similar to an HIV. Physical examination you will do to look for various clues of various, phenotypes of T cell deficiencies. Then you will do your CBC first step. Then you will do your TBNK or your lymphocyte subset that is there. And then here you will not just give immunoglobulin replacement, etc. But because these are severe, you will consider gene therapy, you will consider bone marrow transplant as well. So bone marrow transplant and gene therapy are important in this case. Phagocytic defect, again, this is a severe one, but a lot of times these phenotypes are, kind of hypomorphic. What do you mean hypomorphic? They do not present in a complete manner, right? So a lot of times the patient may present with only few abscesses, and then the patient may be even ignored unless if the patient presents with a liver abscess, etc. Then you will work up for a phagocytic cell defect. So here you will have to nicely examine for any presence of underlying abscesses. Then you will do your mainly respiratory burst. Say CD11-18 in your leukocyte adhesion defect you will have to do, but otherwise it's mainly respiratory burst assay. And here also you will consider bone marrow transplant apart from your antibiotic prophylaxis. And another thing here is your interferon gamma replacement. Interferon gamma replacement is also a good modality in your phagocytic defect. Then coming to complement defect, here again we discussed this. Here there are two types of abnormalities can occur. One is hereditary angioedema. So this angioneuritic edema, this also is another chapter that we are not going to discuss here. This is something like an immune dysregulation. So that is there you treat with a separate set of factors. There you basically do not want that pathway to kind of increase, right? So there you basically want to give C1 esterase inhibitor. So that is a different pathway. In whenever you have a hypocomplementemia, there you will basically look for treat with antibiotic prophylaxis only. You will monitor for autoimmune disease. If you're especially early complement pathway, you'll have a increased risk of SLE. So that and all will be there. So you will basically treat with prophylactic antibiotics and vaccinate the patient well, and you will avoid autoimmunity. So that is what you do in complement defects which lead to hypocomplementemia, unlike this whole thing which is hereditary angioedema. So this is your basic approach to therapy. Basically you will either replace the missing protein, that is your antibody, you will give IVIG, you will replace the missing cell type, that is you will basically transplant the bone marrow, or you will use gene therapy. How do you use gene therapy? Basically you will take the hematopoietic stem cell, you will transfuse them using some bacteriophage or etc. and then reinfuse. So gene modified hematopoietic stem cells will be there. So these are basically not useful for all the diseases. It would be great if it could be, but mainly it is some forms of severe combined immunodeficiency, Wiskott-Aldrich syndrome, and some phagocytic defects. As I told you, phagocytic defects will have also bone marrow transplant, gene therapy, and gamma replacement, interferon gamma replacement. So in CGD, leukocyte adhesion defects, you can do gene modified cells, severe combined immunodeficiency, and Wiskott-Aldrich syndrome. These are your three main diseases, 3-4 main diseases that are there. Then you have, so protein replacement like by using IVIG, or you can use other gamma interferon replacement, ADA, which is one of your basic things that you is defective in severe combined immunodeficiency. Then cell replacement, either bone marrow transplant or HSCT, and even sometimes your hematopoietic stem cell transplant, basic ones that are there, CD34, you can use them. Gene replacement therapy we talked about. Then CRISPR-Cas9, where basically you're doing gene editing, you're changing the gene into a more preferred gene. Apart from this, obviously you can give enzyme replacement, we discussed ADA, and antibiotic prophylaxis is also important apart from all of these. Then takeaway are basically the diverse group which we have not discussed in much detail. We have mainly looked at the approach. If a patient is coming with these recurrent infections, what are the tests you will do, what are the things that you look for in history and physical examination, and what can lead to a probable diagnosis, and how will you approach the treatment. We have only talked about approach. For each disease, how it will present, what are the nitty-gritties of the phenotype, obviously you have to go through our PID lessons. And also it's a never-ending chapter, right? It's an ocean. We're not going into detail there also. And to be very frank, it's not required for you, neither as a general pediatrician or a medicine resident. It's not required as much. The most important one is your approach, right? So that is important. Then always remember there is a sense of autoimmunity and a possibility of malignancy as well. Then warning signs I talked about, classification to some extent, just our basics we discussed, and our approach and treatment are ones that you should keep in mind. So this we finish this PID approach as well. So this is, again, as I told you, do not try to go in depth. Harrison itself, it's given slightly more in depth. I would suggest just go through this chapter and the chapter that is given in our NEET assessment.